Good afternoon, folks. Thank you for inviting me to participate in this symposium. In my earlier life, I was a general dentist for 23 years before I went over to the States and was trained as an endodontist. And I have been working as an endodontist for the past 15 years. So it is very unlikely that I will see so many elegant restorations like what I saw today. So kudos to those speakers ahead of me who, did such nice work. I just envy their skills. Now that these speakers have talked about what they place on top, what I'd like to discuss with you folks is what I do underneath their restorations. And this is what I call foundations. So for those who do makeups, foundations protect the underlying skin and enables whatever makeup you put on top to stay longer. And for those who own houses, you realize the importance of a foundation. Without, first treating the termites, your house, no matter how elegant it is not going to last long. So the same happens, the same applies to disinfection of dentin, because disinfection of cavities and tooth preparations will increase the longevity of whatever you place on top. Again, like your direct resin composites, your zirconia, and 3D printed restorations. Now, I was asked to provide a conflict of interest statement. So my laboratory receives funding from Largent Health, LLC, for conducting research on FiteBac Cavity Cleanser. So we have been doing this for the past 5 years, plus other products that Largent Dental Health is working on. So before I begin with my presentation, I am going to ask a couple of questions. The first CE question is, in the vital tooth, ingress of bacteria noxious products into the dental pulp is prevented by A, T lymphocytes within the dentinal tubules, B, outward flow of dentinal fluid, C, odontoblast processes, D, toll-like receptors that recognize pathogen-associated molecular patterns, and E, endocytosis, which means a process of how materials are actually engulfed by cells, in this case, by macrophages. So 10 seconds. Okay, the second CE question is, which of the following is not an example of a commercially available cavity disinfectant? A, silver and gold nanoparticles. B, benzalkonium chloride. C, chlorhexidine. D, quaternary ammonium silane. And E, Bactrin. And again, 10 seconds. Okay, folks, I'm going to divide my presentation into 5 sections. The first section is, why do we have to disinfect our cavity preparations? There are 2 reasons. Number 1, it is the substrate we are dealing with. And number 2 is how dentists treat these substrates. So first, I will talk about our substrate. We all know that caries is caused by bacteria, and caries is a biofilm disease. Time doesn't permit me to go into the specific biofilm composition in subjects with and without caries. What I'm showing here is actually a confocal image series that was taken of dental plaque grown on top of a dentin disc. So I took this with a confocal laser microscope, and what you are looking at actually is a stained biofilm of dental plaque, and the green bacteria, you can see different types of bacteria. Some of these are spirochetes, some of these are filamentous bacteria, cocci, so you name it. So the green bacteria are alive. So these are living bacteria, and the red bacteria are dead bacteria. So not only are we dealing with primary caries, but in restorative dentistry, we are also dealing with secondary caries. And in fact, secondary caries is the main cause of failure of dental restorations and fixed prosthesis. Now, in this paper from Belgium, these folks were showing that the age of restorations with secondary caries. And what is shown here is resin composites do not last as long as we wish them to be. And most of the time, resin composite restorations, particularly direct restorations, they won't last more than 7 years. And the odds ratio of the survival of these restorations is affected by the type of restorative material. Like composite, they last much less than amalgam. The restorations that class 2 restorations are more at risk than class 1 restorations. Those with high caries risk obviously are more at risk, and smokers are also more at risk. So this is basically the substrate. And the second issue, like I said, why do we have to disinfect dentin, is how we as dentists remove caries. Now, it is highly unlikely that in a carious tooth we want to expose the pulp by removing all caries. So this is a paper that was published in 2019 by the International Endodontic Journal. But it's a position statement by the European Society of Endodontology. And what it actually says is it describes methods, that recommendations for the management of deep caries. And what they recommend is to do a stepwise excavation of caries removal in order to avoid pulpal exposures. Now, unless you really want to do root canals, you want to avoid exposing the pulp as much as possible. And this concept of selective caries removal is based on the work of a lot of gurus in cariology, like Mori Masler, Dr. Takayo Fusayama, Edwina Kidd from the United Kingdom, Ole Verjeskov, and lately Lars Bjorndal. So these are the gurus who actually recommended stepwise caries excavation, which most of us would be doing in our practice. So this is basically how we do it. So we have a tooth that is extremely carious. So we do stepwise excavation, removing all those that soft dentin, the so-called caries-infected dentin, excuse me. And then leaving behind those hard, firm, leathery, so-called caries-affected dentin. Now, so far, this is absolutely acceptable. Most of the dentists would be doing it this way, rather than exposing the pulp and have to do a pulpotomy or root canal treatment. So, but what most dentists do not realize is what they are actually leaving behind. So in order to understand this, my colleagues and I did a paper back in 2020 in which we looked at 12 teeth. So my colleague actually filled these teeth, and then after different times, 9 months to a year, he extracted those teeth and processed them for histology and also to stain for bacteria. So to our surprise, all these teeth, which we try to do selective caries excavation, they have stainable bacteria in the dentin. That doesn't surprise me, but what surprises me is these cells are all chronically inflamed. In other words, whenever you try to leave caries in dentin, even if the dentin is hard and leathery, you always have, inflamed, an inflamed pulp. So whatever elegant restorations you are putting on top, you are just putting the restoration on top of an inflamed tooth. So let me show you an example. So this is a tooth number 1 that was restored using selective caries removal. So this is hard and leathery dentin that was ultimately restored with a resin composite and extracted 3 months later for whatever reason. And so this is a cross-section of the tooth showing the resin composite restoration. And this is the so-called caries affected dentin. And this is the pulp horn, which is shown in this histological section. Now, in the area that is circled here, you can see that there is a lot of inflammation here, which I'm going to show in a minute at high magnification. But the rest of the dental pulp is pretty healthy. And when I look at the high magnification of the previous images, what you can see is there is an accumulation of chronic inflammatory cells. The blood vessels are congested with red blood cells, and these are examples of lymphocytes that are present in the dental pulp. So the tooth is under a chronic inflammatory state. So these are Brown and Brand stains. Brown and Brand is a type of stain that we use to stain bacteria. So it stains the dentin yellow, it stains the hybrid layer, which is shown here as a very thin red line. So that is your hybrid layer. When you etch dentin or when you apply a self-etching primer to dentin, you remove the minerals and you put resin in, and this is what it looks like when it's stained. But what is quite surprising is there are a lot of bacteria inside these dentinal tubules. Now you see all these perpendicular lines. These are dentinal tubules, and inside the dentinal tubules, all the bacteria, the dentinal tubules are filled with a lot of bacteria. So we do have chronic inflammation, even if we try to remove the dentin to achieve hard and leathery kind of caries affected dentin. So we are dealing with a substrate when we remove caries that is infected, and that's why we have to disinfect dentin. So these are high magnifications of the hybrid layer, and these are the dentinal tubules, and at even higher magnification, you can actually see the cocci, right, the straps inside the dentinal tubules. So again, in this image. Now you may say, with so much bacteria inside the tooth, how come most of my patients, they never complain? Well, I do agree with you folks. You know, if every tooth that dies, then endodontists will be very busy. I can assure you that some of them die, but a lot of them will survive. And there are 2 factors that actually prevent bacteria ingress into the dental pulp. So let us look at these 2 factors. Number 1 is the outward flow of dentinal fluid. And the second one is the presence of the so-called tertiary dentin or reparative dentin. So let us look at the first factor. Trying to remove this. So what you are looking at in the upper left image is a dentin surface with the smear layer removed. So you can see the dentinal tubules very well. And here you see the intertubular dentin, and this is the peritubular dentin. So with such a substrate, if you're trying to, like in this particular case, I'm forcing a blue dye, you know, from the pulp through the dentin, you will see that this dentin is very permeable, particularly near the pulp horn. So as long as the pulp is vital, the outward fluid flow through the dentinal tubules is an important mechanism in which noxious materials permeating through dentin are cleared from the pulp. Now, folks, what I'm showing at the bottom images is a paper that I published almost like 25 years ago. Now, at that time, I was a general dentist, and that was the time when SARS-1, I don't know whether you remember that. I was originally from Hong Kong. So SARS-1 was happening, so I have nothing to do. So I did my crown preparation like a lot of you. And instead of pouring my impression, I was taking an impression actually with an ultra light body polyvinyl siloxane impression material. Instead of pouring it in stone, I thought it would be fun to pour it up in epoxy resin and examine it under a scanning electron microscope. And to my surprise, I see droplets of dentinal fluid coming through my crown preparation while I'm taking an impression. Now, what does that tell me? A tooth, particularly when it is in deep dentin, is highly permeable. We have dentinal fluid coming out of the tooth. Now, that may be a bad thing, but sometimes it may be a good thing too, because the dentinal fluid contains plasma proteins. The plasma proteins and the dentinal fluid, such as albumin and fibrinogen, they help to reduce the permeability of dentin to the inward diffusion of noxious products, as shown as this cartoon here. So we have bacteria trying to secrete a lot of the noxious products like thromboxanes, prostaglandins, all kinds of things that or lipopolysaccharides. So these kind of things, they try to diffuse into the dentin to actually try to kill the pulp. But then we have also an outward flow of plasma proteins that pushes them back. So folks, what we are seeing here actually is a balance. In a vital, normal, healthy tooth with a normal pulpal fluid flow, right, there is what is known as homeostasis. In other words, the outward fluid flow will push the noxious products back. So far, so good. So far, so good, until we as dentists try to interrupt. Now, the patient comes to our office asking for a restoration. So in order to do the restoration, we have to numb the tooth up. And most of the time, we are using a local anesthetic with vasoconstrictor, like epinephrine. Now, what I'm showing here on the left diagram here is, say we have a high concentration of irritants from the bacteria noxious products. So in a normal healthy pulp with a normal pulpal fluid flow, which is around 15 to 16 centimeters of water, the outward fluid flow would pushes those products back. And those products are never too close to the pulp. But once we try to numb the tooth with a vasoconstrictor, we are reducing the pulpal fluid blood flow. So what happens is, if you give one carpule, then the noxious products get closer to the pulp. If maybe you get 1.5 carpule, then the noxious products would go directly into the pulp. And actually, if you give enough, you can actually reduce the pulpal fluid flow to 0. In this case, the irritants would just go right in. Now, what is the clinical implication, folks? The clinical implication is this. During that hour of local anesthetic administration, bacteria, toxins, they can enter the pulp by diffusion to reach a critical concentration so that the pulp says to itself, oh, I cannot stand it anymore. So it gives up, and that's why you have a patient in pain, a tooth that flares up, and the patient calls you in the middle of the night and says, look, doc, my tooth hurts so bad. All right. So this is, something that we see, on a routine basis. Now, as emergencies, and what do endodontists see? Two things. One is a cracked tooth. That's what we cannot save. And the other is something like this, a caries tooth that has nothing. I mean, there's no inflammation, nothing, when you examine it and get the patient's flare up. And this is the reason why. So far I have talked about the first factor, which is the outward fluid flow. And now I'm going to talk about the second factor, which is the presence of reparative dentin. What I'm showing here is the reparative dentin that is formed by a living dental pulp in response to an insult. A caries, for example, is a very good example of an insult. Now, unlike secondary caries, reparative dentin or tertiary dentin does not have a lot of dentinal tubules, which is a good thing because now the patient does not complain of dentin sensitivity. It also blocks toxic products from entering the pulp. Now, what I'm showing here on the right is a classic experiment that was done by Margie Byers in the early 90s. So she was using nanogold particles to simulate bacteria toxins. So if there is normal dentin without reparative dentin, these nanogold particles will go right through the dentin into the dental pulp. But in the case of a reparative dentin, if you have reparative dentin, everything is blocked. So these are the dead tracks. So there is nothing entering the dental pulp. So reparative dentin is a very good way of blocking bacteria ingress into the dental pulp. So far, so good. But it doesn't happen every time. So this series of images is from another paper that was published by myself and my colleagues in the Journal of Dentistry in 2019. So this case is particularly interesting because this is a case that shows a very nice wall-off of the bacteria by the tertiary dentin. You can see that this is the reparative dentin. It blocks off all the bacteria, but bacteria are not stupid. They find the easiest way in. And now they got in through an area without the tertiary dentin, and that's why it's infected. Or you can see here the dentinal tubules open on the pulpal side, and these filamentous bacteria got into the dental pulp and infected the dental pulp, and here we got an abscess. What is an abscess, folks? Abscess means there is pus. So when you expose the dentin, you will see pus coming out. Now, fortunately for this young gentleman, all right, the infection is only partial. Here we have a micro abscess, and further down we have chronic inflammation, which at higher magnification, you will see that there was a lot of chronic inflammatory plasma cells. But underneath, everything is healthy. So fortunately for this 16-year-old gentleman, right, what we can do is what we call a vital pulp therapy. So you just scoop out the infected dentin, arrest the bleeding. If you can arrest the bleeding, then you can just apply a tricalcium silicate cement known as MTA. I'm sure a lot of you have heard of this material. It is used by a lot of dentists for direct pulp capping. And so we put mineral trioxide aggregate over here, and this tooth can be saved reasonably well without the need for a root canal treatment. And of course, if the tooth eventually dies, which is fairly unlikely, we can always go back to do a root canal. So this is what we teach our residents these days to save young permanent teeth. So I hope by now, folks, I have convinced you that there is a necessity. Whatever elegant restorations you put on top, you need to treat the foundation well before you need to disinfect the dentin before you actually do your restoration and take your impression. So how are intraoral disinfectants classified? So before going into the classification, let's talk a little bit about history. Pierre Fauchard is the first person to mention treating caries with a disinfectant. His method, however, did not stand the test of time. So the first person actually to talk about antimicrobial dentistry is Martin Bramstrom from Sweden. So he is actually the father of contemporary antimicrobial dentistry. In this paper published in 1973, he was using 3% sodium fluoride with chlorhexidine. Chlorhexidine, of course, you know that this is a disinfectant, and sodium fluoride is also, it does kill bacteria by altering the bacterial metabolism. So this is the basic classification of disinfectants used in restorative and prosthetic dentistry. First, we have a whole series of cavity and tooth preparation disinfectants, which I'm going to talk a little bit more today. And then we have also a large category of adhesives that contain antimicrobials. And because I'm not going to talk about this in detail, I will just mention that there are two groups: the commercialized and the experimentals. There are 3 commercialized products, and you have seen Mr. Clementino, if I am not mistaken, from Curare. Now, this is their company's product, Clearfield Protect Bond, which contains a quaternary ammonium bromide and antimicrobial resin known as MDBP. We also have Gluma 2 Bond, which contains glutaraldehyde. Now, don't argue with me whether glutaraldehyde is FDA approved. I'm sure if it is sent to FDA for approval, it won't be. But this product has existed in the market for many, many years, and it is still one of the most effective bonding agents. And then we also have Peak Universal Bond, which contains chlorhexidine. For the experimental side, we have a lot of products with quaternary ammonium methacrylates. We have nanoparticles. We have bioactive glasses that are doped with antimicrobial nanoparticles. We have copper iodide, tricloxan, quercetin, grapeseed extract, and also this product is from Largan Dental Health, quaternary ammonium silane methacrylate. So we have, all these examples of adhesives containing antimicrobial agents. What I want to alert to you folks is not every one of this product is actually can be copolymerized with your adhesive agents. In other words, you must have a methacrylate functionality before they can copolymerize. So examples being the Protect Bond. This is a methacrylate product, and this is a methacrylate product. Now, if you just add chlorhexidine, for example, it will be trapped within the polymer matrix, but eventually it will leach out. So the way of killing is completely different, because if you just put chlorhexidine, it will kill. Of course, it will kill bacteria, but it will kill bacteria very quickly in what is known as a burst release mode. And then slowly it will die down, and then the antimicrobial activity will slowly become zero. So you want to get products that is copolymerizable with the methacrylate resins that you are using in the dentin adhesives. So for those who are interested, I'm leaving a paper here for those who want to read more about this topic. So that is So this is the paper I was talking about, adhesive systems modified with antimicrobial agents. So the second category, so these are examples of the second category, the cavity or tooth preparation disinfectants. So sodium hypochlorite, of course, Clorox is one of the most useful disinfectant, although it is extremely corrosive. It is highly caustic, and if you are not careful, you can actually generate a sodium hypochlorite accident, which happens in my department anyway. So we have also other products like Cavity Cleanser from Bisco and Concepsis from Ultradent. So these are examples of chlorhexidine products. We have examples of benzalkonium chloride. A very good example is Tubules Red. And there are 3 versions, the blue and the green, which I'm not going to talk about. Iodine potassium iodide is a small used in Europe than in the US because of potential iodine sensitivity. We also have a product called NanoCare, which is silver and gold nanoparticles. So you apply that to treat your dentin surface. We also have phytochemicals, like there are a few of them, but propolis, which is the beeswax, is the most popular antimicrobial. We also have laser. You can kill bugs with laser, or even ozone therapy. And the latest to be introduced in the market is this FiteBac Cavity Cleanser, which is 2% quaternary ammonium silane, which I'm going to elaborate in my next session. But before I go into that, there's some problem with my pointer. Okay, good. So this, again, is literature for those who are interested in reviewing a little bit more about these cavity disinfectants in restorative dentistry. Now, one of the issues that make cavity cleansers so important is, apart from killing bugs and fungi, they also have a very important subsidiary function. Cavity disinfectants like chlorhexidine, benzalkonium chloride, and other quaternary ammonium compounds, they are potent inhibitors of dentin matrix metalloproteinases. So what are metalloproteinases? This is a class of proteases, a class of protein hydrolyzing enzymes that are trapped in an inactive form in dentin after tooth formation. So they stay within the dentin. But when you etch dentin with phosphoric acid or a self-etching primer, you dissolve the minerals and you activate these enzymes. And now they begin to chew up the collagen in your hybrid layer. If the hybrid layer collagen is not properly enreved by resin, they will be easily degradable by these enzymes. And there are three major enzymes in dentin: MMP2, MMP9, and MMP8. So what I'm showing here, folks, are two examples of degradations. On the left, well, these are actually bonded by single bond, actually. So what you're looking at here is a transmission electron microscopy image. So transmission electron microscopy is a microscopic technique that you look at a very, very thin section. How thin? Imagine if you have a piece of paper, you cut it into 9 pieces. All right. So that is how thin your section is. So light can actually pass through. Now, what we are looking at here on the left is immediately after bonding with single bond. So this is dentin, the dentin surface. You have the resin composite here, a dentinal tubule. This is the dentin, and this is the hybrid layer that is created by acid etching. So what happens if you leave it behind? 12 years. So this is actually taken from a tooth that was extracted after 12 months of intraoral function. The hybrid layer will degrade slowly. And here you can see that the hybrid layer is no longer visible. You still have the dentinal tubules, but the collagen has degraded. They are chewed up by the matrix metalloproteinases, the MMPs. Of course, your restoration is not going to fall off after 12 months, but slowly they will degrade, and eventually it will leak, and then you will have secondary caries. So a cavity disinfectant, particularly the quaternary ammonium compounds, they will prevent this degradation. So something about ozone. Now, in my department, we try to teach residents evidence-based dentistry. And so how good is ozone in reversing the decay process? So this is actually from the Cochrane database systematic review. And what it says is there is no reliable evidence that ozone, right, apart from being very expensive, of course, All right, application of ozone to the surface of decay teeth, there's no evidence that it will stop or reverse the decay process. The same thing applies to laser. Now, manufacturers, of course, would like you to use laser for hard tissue removal. All right, lasers are wonderful for soft tissues, but is it good for hard tissue removal, like removal of decay? Now, there was, again, and this is a systematic review from Cochrane Library, there was no evidence, or evidence was insufficient to support the use of laser as an alternative to traditional drill therapy for caries removal. So apart from being expensive, there is no place for lasers and ozone therapy in caries removal, at least with the evidence that is available today. Now, what is important about all those cavity disinfectants that I was describing, except for one product which was approved recently? All these products, no matter whether they are chlorhexidine or benzalkonium chloride, they are not FDA approved, unfortunately. So let us talk a little bit more about the FDA approved quaternary ammonium silane disinfectant, which is what my sponsor wants me to talk about today. So this is the FDA approval of the 2% quaternary ammonium silane in ethanol. This is the FiteBac Cavity Cleanser. A little bit on the synthesis. I know that we are not chemists here, but I just want you to know the mechanism of how this compound actually kills bugs, right? So the compound is synthesized from two ingredients, a tetraethoxysilane and a cyquac, which is a quaternary ammonium silane. Now the TEOS, the tetraethoxysilane, acts as an anchor because it has 4 of these siloxane bridges. So what it does is it creates a platform to add other molecules by the formation of siloxane bonds, as I will be showing you in a minute. The cyquac is a compound that it has antimicrobial activities, mainly because of this very long 18-carbon chain. So it actually acts as a knife that actually pierces through bacteria, cell walls, and cell membranes. Now, this is a good point, folks, because if you depend or rely on other mechanisms like reactive oxygen species, now the killing mechanism may be bacteria specific, but in this case, as long as there is contact with the bacteria, it will pierce through the cell membrane and kills the bacteria. So this is the silane. Now, another good point about silane is it will bond to your glass fillers. So imagine you have a resin composite, it will stick to a resin to a resin composite. So the way that we actually synthesize this material is through a very simple process. You just mix the two together, and that's it. So this is the so-called sol-gel reaction. So you change it from a liquid to a gel, all right? From a liquid to a solid. And these, folks, are the siloxane bridges that I was talking about, the SiO-Si bond. So this is how the molecules are linked together. Now, what you are seeing here is just a representative of a spectrum of molecules that is synthesized. With sol-gel reaction, you can never have a very pure product. So you will have a mixture of dimers, trimers, oligomers, and you name it. Okay, but this is the predominant molecule that is present in the FiteBac Cavity Cleanser. So what you see on the left here, folks, is the gel that I was talking about. Once you mix it and heat it up, you will form a gel. This gel is insoluble in water, but is soluble in alcohol or acetone. Now, so this is the FiteBac Cavity Cleanser, right? 2% QAS in ethanol. So one drop is dispensed onto a surface, and once you add water, it will precipitate immediately because it is not soluble in water, so it precipitates. So what does it do when we apply this on dentin? So these are scanning electron microscopy images of dentin. You see the dentinal tubule here. This is the dentin that was fractured. This is the collapsed collagen layer. So once we apply the FiteBac Cavity Cleanser, we see a precipitate that is formed on the surface. And when I first saw this, I said, oh, no good, no good. Because you don't want to precipitate that adversely affect your bonding. But I was surprised because once you apply an ethanol-based or an acetone-based dentin adhesive, that precipitate will redissolve and push down the dentinal tubules. And inside the dentinal tubules, it will phase separates again once it comes into contact with water. So these are the phase separation droplets of the 2% quaternary ammonium silane within the dentinal tubules. So imagine if you have something like this, what will it do to the dentin? Two things. Number one, it will remain inside the dentinal tubules, and once it comes into contact with bacteria, it will kill the bacteria by puncturing holes in the bacteria cell membrane. And secondly, this is important because it will reduce the permeability of dentin, because it blocks up the dentin. And what does that mean? Number one, it reduces dentin sensitivity, and number two, it reduces the susceptibility of dentin to water contamination. So how does the application of a 2% quaternary ammonium silane affect our bonding? So this is the paper that was published by my postdoctoral student who came to my laboratory for 1 year. So I put her on this project, and we used two types of adhesives, prime and bond NT, which is an acetone-based adhesive, and single bond plus, which is an ethanol-based adhesive. And we use a bonding technique known as the micro-tensile bond testing technique. So basically, we cut the tooth, expose the dentin, bond, and put a composite, and then we cut it into slabs and stakes, and finally, we put it in a testing machine and pull them apart and calculate the bond strength. So this is the control without adding anything. So this is just the prime and bond NT. 2% QAS and versus 2% chlorhexidine, which is a pretty commonly acceptable antimicrobial. So we can see that there is no difference, no statistically significant difference in bond strength between the control, the 2% quaternary ammonium silane, and the 2% chlorhexidine. The same is applicable for the single bond plus. So in other words, even if it forms a precipitate initially on the collagen surface, the application of an adhesive will redissolve the precipitation, push it down, and it does not affect the bond strength. What about permeability? Like I mentioned, we want our interface, our hybrid layer, our resin-dentin interface to be totally impermeable so that we have a good seal. Is that possible? So one of the way I tested it in my laboratory is to apply a fluorescent stain to the adhesive. Like in this case, prime and bond NT, I just apply LX fluor, which is a yellow fluorescent dye. So that's why the hybrid layer and the dentinal and the resin text, they fluoresce in yellow. So after bonding, we applied through the pulp a column of 20 cm of water that contains a fluorescent blue dye. The whole idea is to see how well sealed is this interface. Okay, so we want to push water through the bonded surface. Ideally, if you have a perfect seal, folks, these two layers should not overlap. You should not see anything green, in other words. You would have blue water and a red resin text. So this is the ideal situation. So when we look at the real situation, you see that there is always some kind of overlap. Okay, so this is the control, 2% quaternary ammonium silane and 2% chlorhexidine. Again, in research, you cannot just look at one sample and say, oh, yeah, that's it. That is not going to happen in research. We must resort to statistics. And so when we examine 10 teeth together, we look at the percentage of interfacial permeability. This is what we found. Both the control and the chlorhexidine, they are more permeable than the 2% quaternary ammonium silane, which means that the precipitates inside the dentinal tubules, it reduces interfacial permeability, and there is a better chance in attaining a fluid-tight seal. So this is important, folks, because chlorhexidine and quaternary ammonium silane, they kill bugs too. But this one makes the dentin less permeable, and the patient is less likely to have dentin sensitivity or dentin hypersensitivity after your restoration. And the restoration is going to last longer because it is less water permeable. What about the clinical manipulation? Now, I'm not a restorative dentist anymore, but basically it is pretty simple. And I got this case from Dr. Lincoln Fantasky, who provided me with this beautiful case of a class 1 cavity preparation. So what he did was he isolated the tooth with rubber dam, which is very, very good. And then he removed the caries, and he used, this is a caries indicator to stain the caries. I'm sure you folks would agree that a caries indicator does not stain bacteria. What a cavity cleanser, a caries indicator does, it stains pores within the dentin. And caries dentin, as you know, is much more porous than sound dentin, and that's why it stains green or red, depending on the indicator you are using. So we removed Dr. Fantasky removed the caries dentin, and then he dried the dentin, and then he exit etched the dentin. Well, there are three types of etching: the total etch technique, the etch and rinse technique, the self-etch technique, and the selective etch technique. So it really depends on, it doesn't matter what your treatment philosophy is. If you are applying a self-etching primer, you simply apply the cavity cleanser prior to your application of your self-etching primer. But in this case, he was using 32% phosphoric acid. So after that, he rinses off the acid, gently blow dry without over desiccating the dentin, and then apply the FiteBac Cavity Cleanser and rub it into the dentin for about 20 seconds. And slowly air dry to make sure that there is no pooling of the cavity cleanser. And then apply your adhesive, air dry your adhesive, and then light cure your adhesive, and then put whatever composite you want and finish the case. Now, although he has given me a class 1 cavity, the same technique can be used for crown preparations, for deep dentin, for class 2 restorations, you name it. All right, and actually, it is very good for use before immediate dentin sealing, as recommended by Dr. Pascal Mania. So what you need to do is after your crown preparation, you apply your etchant to remove the smear layer. Then you apply FiteBac Cavity Cleanser, and then you seal your dentin with your adhesive. Apply 2 coats. Make sure that you have complete polymerization, and then you remove the sticky oxygen inhibition layer before you take your physical impression. Or if you are taking a virtual impression, then you don't even have to worry about that. So what about antimicrobial effectiveness? How effective they are? Like I mentioned, this cavity cleanser contains quaternary ammonium compound with a long salt-like, chain that pierces through the bacteria membrane. So it really doesn't matter what type of bacteria you are dealing with. It will still kill once it comes into contact with the bacteria. So what you're looking at the left is dental plaque that is grown on a dentin surface. And on the right, you have the same dental plaque, of course, in a different specimen that was treated with the FiteBac Cavity Cleanser. Now, like I said before, red means dead bacteria and green means live bacteria. So in this case, you will see more red than green. There is always some green because, like I said before, it kills by contact. So if it is the bacteria are not in contact with the quaternary ammonium silane, it is not going to be killed. So far so good. But just looking at two pictures, I'm not convinced. So we have to, again, to resort to confocal laser microscopy for statistical analysis. For what we are doing here is we grow a single species biofilm on top of a dentin disc, and then we analyze the live and dead bacteria within the biovolume. We have the same three groups, the control with nothing, the 2% quaternary ammonium silane, and 2% chlorhexidine. And then from that, we calculate the dead live bacteria ratio, which means that if you have a higher number, there will be more dead bacteria compared with the control. So in this particular case, both chlorhexidine and quaternary ammonium silane are way better than the control in killing bugs, and there is no statistically significant difference between 2% chlorhexidine and 2% quaternary ammonium silane. So folks, you all know that strep mutans is one of those bacteria that is responsible for initial primary caries. Of course, we can also look at other bacteria like strep sobrinus, strep. My mind just become blocked. Never mind. Let me name another one, lactobacillus, for example. So these are the early colonizers. Like I said before, even with these early, although we haven't looked at it, they are going to kill in a similar fashion because they simply punch holes in bacteria. We did look at another bug, in this case, Actinomyces nestlandi. Actinomyces nestlandi, like Actinomyces viscosus, they are found in root caries, and that's why we are interested in looking at how they are killed. In this particular case, again, they are much better than the control, and there's no difference between 2% chlorhexidine and 2% quaternary ammonium silane in terms of their killing efficacy. So next, we want to see how well does the dentin resist MMP degradation. Like I said before, MMP is matrix metalloproteinases. Those are the enzymes that are present and trapped in the dentin that are activated by your adhesive. If you are actually looking at the degradation of dentin, it will take a long time for this experiment to finish, 12 months. So this is not feasible. So in my laboratory, we took a clean dentin slice, we polish it, and then grind it to about 50 micron thick, and then we stick it to a glass slide, and then we apply a gelatin solution. Gelatin, as you know, is collagen after breaking down, after hydrolysis. So we add heavy quench fluorescein, which is because of quenching, it is not going to have fluorescence. Now we incubate this slide for 48 hours in the dark. So any enzyme that is present in the hybrid layer, that will release the fluorescein. It will degrade the gelatin, release the fluorescein, and now you can see green within the dentinal tubules and within the hybrid layer. So this is the basics of in situ thermography. So again, we look at our control. So folks, imagine this is your bond. If you are just bonding to dentin, you will see that there's a lot of enzyme activity inside the hybrid layer. And that's why slowly, your restoration will, your bond will degrade. So whatever elegant restorations you put on top, they are not going to last as long. And compared with the use of 2% chlorhexidine and 2% quaternary ammonium silane, you can see that there is less fluorescence inside the hybrid layer, which means that the cavity cleanser was able to suppress the enzymatic activity, which is shown very nicely in this chart here. So with the control, we have a lot of gelatinolytic activity, the breakdown of the gelatin, compared with 2% QAS and 2% chlorhexidine, and there is no significant difference between the two. So what does that tell us? The clinical implication is if you apply one of these cavity cleansers, not only will it kill bugs, but it also reduces the susceptibility of the collagen to be hydrolyzed by enzymes that are present in dentin. So one of our concerns is we want our restorations to last long. When our patients come to our clinic, they want their restorations to last as long as possible. So that's why bond durability is something that we are very interested in. You know, if you place a composite and after 7 years, there are secondary caries, patients is not going to be happy. So that's why bond longevity is something that has interested me and my students for a long time. So this is published in Journal of Dentistry in 2017. So we were looking at FiteBac Cavity Cleanser on the durability of resin dentin bonds. So we were using single bond and primary bond anti again. So we used the control, which we just applied the adhesive, 2% chlorhexidine and 2% quaternary ammonium silane. So this is immediately after 24 hours of bonding and after 12 months. You can see that there's no difference in bond strength. In other words, the bond did not deteriorate after 12 months. I wish I can work longer, but most of my students come to my laboratory for 1 year. It would be nice if we can actually look at these restorations for 10 years. So with all this in mind, it is not difficult now to imagine why we now have a game changer in restorative dentistry. We have, by the application of 2% quaternary ammonium silane in dentinal, we can now treat our dentin substrate, build a strong foundation, kill bugs, reduce dentin permeability, reduce dentin hypersensitivity, and finally increase the longevity of the bonds and extend the life of our restorations and make our patients happier. Although they are, of course, they are happy just looking at those elegant restorations. But if they last even longer, they will be even more happy. Thank you very much for your attention, ladies and gentlemen. So the CE questions. Number one, the answer is outward flow of dentinal fluid. Like I said before, there is a homeostasis. The ingress of bacteria is balanced by the outward flow of dentinal fluid. And in the second question, what do you think the answer is? Bactrim. There's nothing in the world known as Bactrim. I just made this up. There is Bactrim, Bactrim, which is a sulfonamide antibiotic. But again, you don't want to apply an antibiotic on dentin, right? So the answer is Bactrim. Thank you very much. Now, ladies and gentlemen, I was also asked by my sponsor to call upon Dr. Jon Suzuki to comment on the FiteBac Cavity Cleanser. So without further ado, can the organizers bring in Dr. Jon Suzuki, please?
Well, thank you very much. Am I online now?
Yes, you are.
Yeah, I believe so, Dr. Suzuki. I can hear you just fine, and I can also see you in the video.
Very good. But thank you for the very interesting and innovative presentation, Professor Tay. Also, thank you for allowing me to comment briefly on this research and clinical application of the material. Just a quick disclaimer, the remarks that I make in the next minute or two do not represent any of the 4 universities that I hold professorships in, and my remarks for the next few minutes do not represent the FDA, where I'm a special government employee. But FiteBac Antimicrobial Cavity Cleanser is a state-of-the-art dental product designed to prevent secondary caries and stop the infectious process. As a boarded microbiologist, I'm particularly impressed with the ability of FiteBac Antimicrobial Cavity Cleanser to extend its antibacterial activity into the dentinal tubules. This is the primary antimicrobial mechanism to present the growth of Streptococcus mutans and Actinomyces nozombes, the primary etiological agents of secondary caries. There also appears to be an anti-inflammatory component to this particular product. But as a lifelong educator of dental students and the specialties, I'm convinced and I anticipate the incorporation of these innovative technologies into the curriculum very, very shortly. But once again, Professor Tay, thank you very much for the very fascinating presentation, and also thank you for the opportunity to participate. Thank you very much.